Hey, welcome to bonus 2 of Power Up Endo's 90-Day Super GP. In this bonus lesson, we're going to cover a hot topic in endodontics. And that hot topic is whether to perform 1-visit endodontic treatment or 2-visit endodontic treatment. So what I've done is I've hand selected some important landmark studies so that we can briefly go over them and give you some backing when you're making your clinical judgments on whether to perform 1-visit or 2-visit treatment. This is a relatively short video lesson, but it's a really important one because it's going to potentially shape this important decision that you're going to have to grapple with relatively frequently if you're performing endodontics in your general practice. So without further ado, let's get right into it. So the first study that we're going to go over is Sjogren 97. This is a landmark study and it's quoted very frequently, and what they did was they had 55 teeth that they performed single visit or 1-visit root canal treatment on. And these cases had apical periodontitis. They were single rooted cases, and the 1-visit treatment was performed. Now, prior to obturation, they actually sampled the root canals to determine whether or not there was bacteria present. And there were two main findings from this study. So the first main finding is that 44% of the cases, remember these are infected cases, not vital cases, 44% of the cases still had bacteria present right before obturation. And remember, that's after you've instrumented the case and irrigated with sodium hypochlorite. All right, so that's one of the main findings, that a lot of these cases are still harboring some bacteria leading up to obturation. And these are in single-rooted cases with apical periodontitis. The second major finding here is that the status of whether there was bacteria present or not before obturation had a massive, massive impact on whether these cases healed or not. So what they found was if there was a negative culture, so the case was bacteria-free, before obturation, the success rate was found to be 94% in these cases with apical periodontitis. So that's pretty good. These are infected cases, remember. And then if the case was found to have a positive culture prior to obturation, when you fast forward for a period of time, they found that only 68% of these cases healed. And so we're talking about 94% success rate versus 68% success rate, a difference of 26%, dictated by whether or not there was bacteria present in the case before obturation. So this study tells us that potentially, number one, our instrumentation and our disinfection is oftentimes insufficient in resulting in a completely bacterial-free status before obturation. And number two, the presence of bacteria is going to significantly change your long-term success rate, up to 26%, according to this study. So that's important to note. The next study we're going to go over, also done by Dr. Sjogren, but this one in 1991, is a very, very highly cited publication where essentially they had 30 cases that they split into an experimental group with a 7-day application of calcium hydroxide. And then the control group, as opposed to doing no calcium hydroxide, they only applied calcium hydroxide for 10 minutes. And they took samples. And what they determined was that a 7-day application of calcium hydroxide was very effective in removing all bacteria inside the root canal system, whereas the control group with only a 10-minute application of calcium hydroxide did not consistently lead to a system that was free of bacteria. So this was the evidence backing that a minimum of a 7-day application of calcium hydroxide is recommended to render a system and a case that's free of bacteria. So if you're going to utilize calcium hydroxide in certain cases, which I would recommend for certain scenarios, you want to leave it in for a minimum of 7 days. Oftentimes, endodontists will go 7 to 14 days. These earlier studies tally up in the column of considering that you perform your infected root canal cases in 2 visits. However, more recently, this study done by Dr. Sathorn in 2005, and there have been others as well, pooled a lot of the data from various studies on this very important topic. This study specifically found 3 highly cited studies that met their inclusion criteria, and they pooled this data on single visit versus multiple visit treatment for cases with apical periodontitis. And they found that if you actually pool the data and do some statistical analysis, that 1-visit treatment actually was found to be slightly more effective than 2-visit treatment, but it was not statistically significant. So I wouldn't go as far as to say that 1-visit treatment is more beneficial than 2-visit treatment in your infected cases, but it's not so black and white that 2-visit treatment is the way to go for all your infected cases. And it might be that there's, when you look at the big numbers, no statistically significant difference. So you want to take that into consideration. I wanted to give you some studies on both sides of the argument so that you can make an informed decision when you decide whether to perform 1-visit versus 2-visit treatment. The bottom line is that the smaller studies actually favor 2-visit treatment. And a lot of these smaller studies were done a long time ago. This is potentially before some of the advancements that have been made in an increased level of disinfection because of the technology that we have available to us. And the meta-analysis and the systematic reviews show no real statistically significant difference. So I want you to remember that you're the doctor. You are meant to interpret the literature critically. I would encourage you to stay up to date on some of these important topics because you have a long career ahead of you. Dentistry is meant to be a multi-decade career, and you can't just do the same thing that you've always done. You have to have the desire and the willingness to review the literature and the best currently available evidence and make your clinical judgments based off the best evidence that you have at the present day. I really credit my alma mater, the University of Connecticut, and my program director, Dr. Safavi, for encouraging us to not be locked into doing something a certain way for your entire career, but to actually research and interpret the literature and then make your own clinical judgments based on that data, because you're going to get stale in your career if you're just doing the same thing that you were taught in dental school, because things change. There was a time when we were performing bloodletting and lobotomies, but obviously medicine has advanced, and I would encourage you to remember that throughout your career, that things will change and you have to be quick on your feet and be able to pivot when the dental community and the literature encourages you to think outside of what you've been doing up until that point in your career. You may want to seriously consider always performing 2-visit treatment for the cases with massive infection. That's what I do. So cases where you have any kind of abscess, chronic apical abscess or acute apical abscess. In the case of chronic apical abscess, I like to perform those cases in 2 visits so I can ensure that the sinus tract has healed before I obturate the case. And in cases of acute apical abscess, for sure, because I want to know that the swelling is gone and the patient is pain-free prior to obturation. But your run-of-the-mill cases of apical periodontitis, whether that be symptomatic or asymptomatic apical periodontitis, I will oftentimes perform those cases in a single visit because I feel confident in my disinfection protocol. If you feel unconfident, then I would encourage you to stick to 2-visit treatment for those cases. But as you get the hang of it and you feel more confident that you can disinfect the case in a single visit, you may want to consider performing those cases in a single visit as well. But you have to remember that if the patient has an issue, it's a lot easier to deal with that emergency appointment if there's just calcium hydroxide present, as opposed to there being gutta percha and sealer that's set inside the root canal system, because that's going to require you to dismantle all of that in order to attempt to disinfect the case further with more irrigating solutions and potentially more instrumentation with files. So this is a very important topic. I would encourage you to use your clinical judgment, use the data that I've presented for you, and also the data that's out there as our field evolves and make your clinical judgments based off of that. All right, I will see you in the next lesson.